But incontinence is one of those areas where there's huge barriers to treatment. And we've talked about barriers to treatment today, but incontinence has a little bit of a barrier to treatment because there's actually also a barrier on the patient side. Patients don't want to talk about it, they don't really want to go into it, they really don't like you asking questions about it. And there's a huge embarrassment and reluctance for people to seek treatment. So it is actually this sort of silent epidemic in Australia that has a huge burden of disease in patients and on the economy. And so this is one of the treatments for one of the sorts of incontinence that we have. There's lots of different sorts of incontinence, lots of different treatments. I haven't got any conflicts of interest with this talk, and I'm going to be talking about neuromodulation in the field of urology. So there are basically two bladder conditions this therapy is useful for. And so your bladder is an organ that gives your brain sensory messages like, I think I need to go to the toilet, and your brain can sort of say, well, wait to the break, I can't get up and leave right now. But your bladder muscle isn't a muscle that's not contracting. It's actually under the control, or should be under, once you're toilet trained, the control of the brain. So still, until you're actually at the toilet, the bladder doesn't contract. Now, overactive bladder is this condition where, in actual fact, there's these involuntary contractions. So it's not just sending your brain a message that I'm going to want to go to the toilet in a while, but I probably could hold on. It's like your bladder's actually having a physical muscular contraction. So all you can do is squeeze your pelvic floor and your sphincter and try and hold on so that the urine doesn't leak out, and you might win or you might lose. And so that creates symptoms of urgency, a sudden compelling, like, I've got to go to the toilet now, and I really can't listen to this talk because all I'm thinking about is trying to hold on. At frequency, getting up at night, rushing to the toilet, urgency, or urge incontinence where you actually leak some, which may be a drop to a flood, before you actually get to the toilet. And it could be anywhere from sort of here at the door, or getting home, putting the key in the door is the classic one, or once you see the toilet, or as you get to the toilet, or as you're trying to get your clothes undone, or even you've got your clothes down, but you don't even get to land on the seat for a lady, and the urine's starting to come. Whereas in actual fact, normally you should be able to sit down and then voluntary start when you want. So that's what overactive bladder is, and it's a really common condition. It affects about 16% of the population. It's one of the big causes of urinary incontinence out there. And urinary incontinence has huge impacts on people's social ability, sexual function, workplace, enjoyment, depression, exercise levels, ability to go to the gym. What does that affect? It can affect people's self-esteem, mental health, their weight. So it has huge implications, and it's a very, very rewarding area that I'm very privileged to work in, but a lot of people actually don't want to even ask for help. So there's another bladder condition which is kind of like the opposite. So instead of so this has been your worst nightmare, having a queue for a loo like that, or with someone with the loo's busy. So there's another area where people have a problem, and it's the opposite. So when they actually get to the toilet, their bladder won't contract. So there's these two problems that relate to the function of the bladder. So they might get there, have to wait, sing, whistle, tap their bladder, stand. If they normally sit if they normally stand, rock, push, strain, stop, start, may have a feeling of incomplete emptying. And then that may lead them to go to the toilet frequently because they've never emptied out in the first place. They might get urine infections. So this is the sort of opposite. The bladder actually won't contract when they actually want it to. So these are the two conditions that we're actually able to treat with neuromodulation. Now, it's not the first treatment that you usually try for a patient. So with overactive bladder, there's other treatments. Some patients can, with pelvic floor exercises, improve the condition, hold on, retrain their bladder, reduce caffeine or alcohol or things that may be aggravating their symptoms, and that they can modify and control that. They can address constipation that might be aggravating it, or there is actually medication. So generally those are the things that would be trialled first. It's not the first port of call. And there's a number of different medications available in Australia that can help with this bladder control. With underactive bladder, there's no exercises, there's no medications. You either have difficulty emptying, can't wee, and we keep people under surveillance to monitor how much they're leaving behind, or they're taught how to catheterise themselves, so they go to the toilet and insert a catheter to let the urine out of the toilet. So they intermittently, each time they go to the toilet, they put the catheter in and out to drain the bladder. Other than that, for those patients, neuromodulation is really their only other option. So not a lot out there for that condition. So what would happen is patients would they may be referred to a specialist for further investigation when they've failed those therapies, or sometimes they may be referred to a specialist and then they'll have those therapies because their GP hasn't gone through the complete pathway. And if those sort of fail, what would happen if you were referred to a specialist? And one of the things I think that's important is that not every surgeon does this therapy, and so someone highlighted before that maybe if you're interested in this therapy, you'd want to be referred to a surgeon that offers this therapy, otherwise they may not offer it to you. But also, in actual fact, I think what would be really good practice is, that surgeon actually offers all therapies. So they don't just offer this, they'll be able to give you the options of what all the different options are out there. And so the surgeon is likely will take a history and examination, and so in a female with incontinence that could involve an internal vaginal examination, or in a man a rectal examination, a midstream urine test, which is usually just a screening test, and a bladder diary, which will really give an indication of the severity, how much your bladder holds, how much you pass, how often, how much day and how much night. So they're the sort of things that you'd expect following that referral. Now, we generally investigate further when someone's failed all that medical and conservative therapy before looking at neuromodulation with a test on their bladder function called urodynamics, which will actually measure that bladder contraction during filling or lack of bladder contraction when you're trying to empty. So urodynamics is a test, and we talk patients through and support them through it. It does involve in passing a little catheter while you're sitting over the toilet, and I use fluoroscopy, so x-ray at the same time to visualise the bladder. And we can actually measure what happens to the bladder as we can fill someone up and then ask them to empty their bladder. And then failing that on the overactive bladder front, this urgency problem, neuromodulation is definitely a therapy. And there are other options. Injecting botulinum toxin into bladder is another therapy that's available. But in people who bladder doesn't empty, there really is other than catheterisation or monitoring any other therapy. So what's actually involved in the procedure I was asked to talk about, and it's fairly simple. It can be performed purely under local anaesthetic. I usually use sedation, but it's a day procedure. And we do a 2-week trial. We actually test the device for 2 weeks to see if it's improved enough in the patient's symptoms to actually proceed or not. And so decisions made on how effective the therapy is through a trial. And so for 2 weeks, there's just the lead that's put in. I'm going to show that to you in a sec. And then we see them for a couple of times, and they're booked to go back to theatre, either to pull the lead out because the therapy's been unsuccessful, or to put the battery in and complete the implantation because the trial's been successful. So now I might have to go over here to play this little video. So what happens is we're using the third sacral nerve. So through the back, we can actually put a little needle in and we can test we're in the right place. This is the view you didn't get to see. And stimulate the nerve and check that we can see the contraction of the right muscle so that we know that we're in the right place around the buttock as well as on the toe. And so that tells us that we're actually in the right place. In addition to that, we can actually also use X-ray to check where the lead is. And then the patient goes home with this little white battery, which is the temporary 2-week trial battery on a belt. And then we'll monitor their symptoms, their bladder emptying, if that's part of it, their incontinence, and make a decision. And there's a little remote control that's used, which we have now, which may not be the one you had. I don't know if that was it. Yeah, technology is always advancing. So if you look over here, that's the lead. That's where it goes in the third sacrum bone, which is around about here. The temporary battery. Oops, sorry. My hands give you an idea of the size and the actual size of the battery that's implanted if we go ahead. And there's always advances, so that's a programmer, and we're in a transition phase probably over the next 12 months to a programmer that will look more like a smartphone as technology advances. And how successful is it? Well, about 1 in 4 patients don't have a successful trial, so about 3 in 4 go ahead to implantation. And then we have 5-year data, about 2/3 still have success 5 years down the track. What happens with long-term studies is we're always improving the technology, we're also improving our technique and what we know about the patient and lead placements. If you want to look at results from 5-year studies, you kind of are looking at the past if you look now, because you've got what those patients had. So you never know what the results are on what the current advances are. long term for another 5 to 10 years. So what happens, sometimes people can, what could be the potential problems I was asked to talk about. So sometimes people get uncomfortable stimulation or in the wrong place, or it's not working as well. And a lot of the time, we can actually set the program on that little device to multiple programs. So we try different programs, and often we can get around the majority of problems like that. There's very small risks of significant problems, like device getting infected, usually around the time when it's implanted, just like someone who might have a joint replacement, and that's a really bad complication. It has to be removed, but it's less than 1 in 100. So that's a device removal. But there is also, it could be removed because of therapy failure. Sometimes we've had people who've fallen or had some sort of accident, involved in some sort of accident. There's been some sort of trauma, and the device has been broken, or for some reason it's malfunctioned and they needed parts replacing. But as I say, it is a local anaesthetic sedation procedure to if anything needed fixing. They've had improvements. So when I first saw this treatment and was involved as a surgical registrar 25 years ago, we didn't have the minimally invasive technique, and we used to have to do a cut down to the spine to actually implant the lead. And then I went to America 15 years ago to learn this minimally invasive technique with the lead. Soon after, I sort of started work as a consultant surgeon. And the batteries have got smaller, and are probably going to get a lot smaller. We've got antibiotic dissolvable pouches to try and prevent urine infection. We've got better software technology, smarter looking programmers. So there's a few advancements in the future. There'll probably be MRI compatibility. At the moment, patients can have an MRI scan of the head, but it's a particular scan. They can't have it of the spine. And also the patient has to come to see me for programming, and ultimately there's potential that could potentially be done remotely, and the patient wouldn't have to come in. And that's a big thing for Australia, because I have a lot of people travelling a very, very long way for programming. So that gives you a little bit of an overview, hopefully, and then we can all take some more questions. So incontinence is affecting about a quarter of the population in Australia. It affects children. It can affect young women who haven't even had children. It's not just something that happens in old people. It can be a big impact for people getting into residential aged care, no longer being able to live independently. There was a government, so probably about 26% of the population is predicted by 2030, and the government commissioned an assessment of the cost in Australia in 1 year of incontinence, because it's such a hidden disease. If you look at loss of work, loss of productivity, taxes, continence care, over $42 billion per year in Australia on incontinence is the cost of the disease. Billion, that was not a yes. And actual fact, a lot of the time when we're treating incontinence, it's not uncommon for people to come and say they've had problems for more than 20 years. People really hide the condition. They've got to they wait till the kids have left home, or they've stopped caring for their husband who's passed on, or they're planning an overseas holiday. It would be very rare that I see patients that sort of have fairly new onset of incontinence, and plenty of people it's actually decades.
Is there an age limit? So you were saying that women will weather prolong before they...
So generally it happens, I think, in a lot of medical specialties. It's not unique, but it's not exact age, so that you could have someone who is an extremely frail, 50-year-old with lots of morbidity that you thought there was significant risks associated, where you could have someone who's 90 and very, very fit. The oldest patient I've implanted is 87, and if you've got someone who's living independently, who's savvy with the therapy, this person used a computer and was very active, physically fit. So you're really looking at the patient as far as their fitness goes, rather than their exact age.
Look, if you've got a problem like that, don't wait years and years like I did. Just get out there, because it changes your life unbelievably.